Good. Okay. Welcome to the poster session, and please take a seat. This is going to move pretty rapidly from what I see, so if you're presenting, maybe sit in the front, don't go too far away. And we have 10 posters, so 5 sessions each, so I'd like to welcome Miriam up to the podium to present, and I will sit here and just give you a little warning when it's getting to 4 minutes, so come up and welcome.
Thank you, everyone. My name is Miriam Fernandez. I'm working at the Polybistar Research Institute from the University of Valencia, Spain. And I'm going to present the next poster, Empowering Change, the impact of motivational interviewing on reducing frailty among older adults. So, as we know, that the high prevalence of frailty in older adults and its association with a high risk of adverse health outcomes has become a priority for health authorities. However, traditionally, frailty has been assessed and addressed from a unidimensional approach based on the phenotypical model that refers only to the physical condition. Today, the most recent studies demonstrate the need to address frailty as a multidimensional approach, taking into account not only the physical condition, but also the social aspects, psychological aspects, nutritional aspects, and why not, the pharmacological treatment. So in other words, in order to promote effective interventions, we need to take into account the interactions between all these dimensions. So following this approach, an evaluation questionnaire was developed within the framework of the European Value Care project to measure the frailty of the older adults. And subsequently, a comprehensive personalized care plan was developed and implemented for each participant, using the motivational interviewing for its ability, its capacity to motivate and promote behavioral change. As we can see in figure 1, in light of the result of the evaluation questionnaire, of the baseline evaluation questionnaire, the value care plan was developed in a process of co-creation in the primary care centers. Concretely, the professional, concretely social worker, and the participants met in order to establish the psychosocial intervention in light of the result of the evaluation questionnaire, and in order to establish also the goals to achieve by the participant. Taking into account also not only the results of the evaluation questionnaire, but also the interests and preferences of the patient. In this case, motivational interviewing was the technique used, evoking a collaborative conversational style based on empathic listening and respect for the autonomy to reinforce the patient's self-motivation and commitment to change. But why use motivational interviewing and no other techniques? Because in the Value Care project, we wanted to achieve in the long term and in short term the next goals. In the short term, we wanted to detect the psychosocial needs and interests of the person, to know the stage of change in which the person is, and to facilitate through motivation that the person is positioned towards the desire for change by helping to explore and resolve ambivalences about the unhealthy behavior, or habit, and to establish and modify together with the participants the objectives to be achieved. And in the long term, we wanted to increase their social networks and participation in society, to decrease the feeling of loneliness, and also to improve psychosocial fragility. So now, related to the results, during the year-long value care intervention, more than 50 participants, including the psychosocial prescription area, participated together with the social worker in at least 4 motivational sessions. During the motivational sessions, the professional patient interventions allow to monitor and follow the progress of the psychosocial goals set, and to modify them according to the participants' progress, always reinforcing the intrinsic motivation and commitment to change towards healthier lifestyles. More specifically, we observe an increase in social contact with family and friends, establishment of new social networks among other project participants and the community, and a decrease in feeling of loneliness and psychosocial fragility. To conclude, this study focused on improving the care, well-being, and quality of life of older people with frailty. This study provides a broader and more socially sensitive view of frailty in clinical practice, assessing and addresses, as I mentioned before, the multidimensional condition of frailty from a holistic, collaborative, and personalized perspective, where motivational interviewing was the technique to optimize interventions, reinforcing patient motivation for behavioral change toward healthier lifestyles. And that's all from my side. If you have any comment, you can send me an email. Thank you.
Thank you, Marion, and that's fabulous for keeping to time. I'll just call up Jalen now, to Jalen Layton. And fortunately, the way this session runs, there isn't time for questions, but please come up to the presenters afterwards if you have any specific questions. Thank you.
Okay, hello everyone. My name is Jalen Layton. I'm coming from you today from Canada. I work at St. John's Rehab Research Program, which is affiliated with Sunnybrook Hospital in Toronto. So today I'm going to be presenting this work on behalf of my co-authors that are not here today. And the title of it is Introducing the Long COVID Education and Awareness Hub, a public-facing resource. So our research has learned that people living with long COVID, like other chronic and episodic illnesses and impairments, are also being affected by their psychosocial health and well-being, which includes things like managing their daily activities, participating in occupational duties and social roles, engaging in meaningful leisure pursuits. As well, intersectional social factors such as sex, age, gender, race, ethnicity, socioeconomic status, and geographical location are important considerations when thinking about access to timely long COVID rehab and care in Canada. And so our research study was really interested in better understanding the lived experiences of people living with long COVID and their caregivers and healthcare providers working in the context of long COVID, and really getting an understanding of what we can be doing to support public-facing education and resources. So this project was funded by the Canadian Institute for Health Research, CIHR, and it started in 2021, where we pulled together a group of interdisciplinary researchers, scholars, and healthcare practitioners on our team. In phase one of this project, of this mixed method data project, we collected survey responses from over 2,000 people across Canada that are living with long COVID. We also conducted interviews with 52 people living with long COVID, 15 caregivers, and 34 healthcare providers. And then in phase two of this project, we facilitated 8 co-design workshops with long COVID stakeholders to co-design really what I'm showcasing today, but that's what has become the Long COVID Education and Awareness Hub. So it's a hub that supports education and awareness-based resources that are public-facing and meant to help support folks and caregivers who are navigating the continuum of care while living with long COVID. And so the hub, there's 4 different pillars broken down into the hub that were brought out in the co-design workshops, which includes education, advocacy and public health messaging, so health and social care reform and care integration, and peer support. So this hub will be live, a live website. It's at www.livingwithlongcovid.ca. We're hoping to launch it in July of this year. And then for each of these pillars, we've identified with stakeholders some knowledge translation KT outcomes that we can do as part of this hub. So one of them being a documentary series that we just finished filming last week, and we are going to showcase on the hub. As well, we have just been funded for another project that will look at patient navigation models for long COVID in Canada as well. My information is on the screen, so if you do have any questions or you are interested in this project, please feel free to email me at any time. Thank you.
Jalen, that's a massive project and really needed across the world, I think. Next up, Sebastian Lindeblum.
Hi everyone, my name is Sebastian Lindblom. I'm a postdoctoral researcher from Karolinska Institutet in Sweden. I will present to you today, we can call it a research proposal. It's a project that hasn't begun yet. It's about sense making and within the stroke care trajectory. Just a little bit of background to begin with. We know that with the abrupt onset of stroke, it inevitably leads to a sudden change in life for both persons surviving the stroke, but also for the family. And it includes not only the process of rehabilitation and recovery, but also a process of making sense and adapting to a new reality. The recovery and sense-making process often includes the need for involvement of a range of service providers, but also need for intersectoral coordination and collaboration. Unfortunately, as probably in many other places, Sweden faces challenges and struggling with fragmentation and poor coordination of care and rehabilitation, which fails us to provide adequate quality rehabilitation and care, but also, maybe most important, services that are based on the needs of people and their families. At the same time, Sweden is transforming due to a governmental reform, trying to implement the new reform, Good Quality and Local Healthcare, which aims to implement the underpinning values of, let's say, person-centered integrated care, in a sense. However, we have problems taking this policy into practice, and at the moment, the regions in Sweden are responsible for implementing the reform, and there's a gap between policy and practice. And this project focuses on the Stockholm region and the case of the stroke care trajectory there, and contains the hyperacute, the acute, the subacute, and the community reintegration phase, which contains several different care providers, both from the public but also private sector. And the overall aim of the project is to develop a learning network for all of the stakeholders within the stroke care directory. That means stroke survivors, their families, healthcare professionals, managers, civil servants, and policymakers. And to achieve this, the overall aim, we have 5 objectives that we're trying to proceed to. That's understanding the current stroke care directory and how it's experienced by the stakeholders, and how they make sense of the current role, situation, and context, and further to explore the needs of the stakeholders, and also identify facilitators and barriers to developing this continuous learning network. And as I mentioned, we will use sense-making theory and participatory action research, including co-design as well, to develop this interactive learning network to promote person-centered integrated care. And in short, sense-making is the process by which people give meaning to their individual and collective experiences. But it's also a process of rationalizing what people are doing and why they are doing things. And this can be done both as an individual process, but also as a collective one. And to the contributions that we're hoping to get to, we hope to provide learning on how sense-making and participatory action research can be used to promote continuous learning, but also collaboration and knowledge exchange between these stakeholders. And further, contribute with knowledge on how the current networks and how the current stroke care trajectory can transform into a learning one. And the continuous network will hopefully also connect stroke survivors and the involved stakeholders to promote further learning and knowledge sharing, but also implement best practices and new innovation, and hopefully in long term improve patient experiences and outcomes. Thank you.
Thank you, Sebastian. You'll have to come back in a couple of years and report on your progress. Next up, Claire Ramsey. And Sabrina? You can introduce yourselves.
Hello everyone, my name is Sabrina Lynn and this is my colleague Claire Ramsey, and we work for the Northern Health and Social Care Trust here in Northern Ireland. And our poster presentation today is really to give you an overview of the Connect North service, which is an integrated social prescribing service delivered across 2 sectors in the Northern Trust area, and those sectors are health and social care and the voluntary community sector. But before we get into the presentation, I'd just like to acknowledge our colleague Mandy Wilson, who's here today representing IJIC. And it's IJIC who deliver Connect North in partnership with us as one service for the whole of the Northern Trust area. So Connect North is an integrated social prescribing service for adults living in the Northern Trust, and it recognises that health and well-being is about more than just our physical health, and it's affected by various social factors such as our finances, our housing situation, or feelings of being lonely or isolated. So Connect North aims to connect people with the right help and support to address their social needs, but within their own local community, and that's what's called social prescribing. So I'm just going to give you a wee bit of background to the development of Connect North. In around 2018, it was recognised that within the Northern Trust area, there was really quite a number of navigation, link worker, connector, social prescribing type services that were available, and they were all doing fantastic work, but it was really becoming increasingly difficult for service users and for referrers to be able to navigate these, and that was really due to differences in criteria, or perhaps it was geography. So depending on where you lived, your age, your health condition, you may or may not have been lucky enough to be able to access these services. And then alongside those, we were having some new social prescribing services emerging for both mental health and cancer-specific conditions. So at that time then, there was a decision taken at director level within the Trust to try and integrate those services into one service, and that was to try and create clear pathways, increase accessibility, and to free up some capacity within each of those services. So following on from that, we embarked on a 2-year period of engagement with our service users and a whole range of providers, stakeholders, referral agents, and that was really, that took place between 2019 to 21, and we had a break there with COVID, but that was really to determine what the core elements of the integrated service should look like and really what mattered to them. And what we found was the outcomes from that engagement was really similar across all of the stakeholders. The service needed to be holistic, it needed to have a single point of access, it needed to be personalised and provide an effective first point of contact, and really importantly, it needed to prevent our service users from being passed from pillar to post and continually having to repeat their story, and that's something that service users say all the time. So another key element of the service was to have a shared directory of services, a single directory of services that was available to everybody, and that included the general public, so that they could access information on services at that really local neighbourhood community level. And the co-production and co-design element with our service users has been very central to the development and the implementation of Connect North. They've been involved in every aspect, what I've already outlined, but also the name, the branding, deciding on what needs assessment tools that would be used, and then they also represent on our steering group. We actually have a service user who acts as our co-chair. So Claire's now going to introduce you to the operational side of the service.
Hi, so our engagement highlighted a very clear and overarching need for a unified directory of services for the Northern Trust area. Population Plus is our accessible online directory. It's available to anybody with access to an internet-enabled device, and it can be accessed via a web link or a QR code as shown on the poster. We built this and it now creates more than 800 services, activities and supports available for clients living in the Northern Trust area. This now means it's no longer necessary to refer clients to a third-party person like Connect North in order to provide that very basic and localised signposting information to address an already known and highlighted social or wellbeing need. By developing Population Plus, it enabled us to create a stepped model of care. That's also shown on the poster. This means that we can support more people with no extra resources to ourselves. At step 1, clients can access information regarding services and supports for themselves or on behalf of a loved one. They told us they needed to know what was available and to have easy access for it, and we've delivered on that. At step 2, where clients are maybe engaging with others, either within their community or within the wider health and social care family, they can be offered the information from Population Plus without either the need to directly access Population Plus for themselves or without the need for an onward referral and the passing of their information to another party. For clients where step 1 and 2 have been ineffective or inappropriate for whatever reason, the client can be referred to the Connect North service to have the one-to-one support of a link worker. The link worker will then undertake a holistic assessment of their wellbeing needs using a validated assessment tool, and that was one that was selected by our service users. That then forms the basis of a conversation to co-create a personalised wellbeing support plan which outlines the agreed actions for both the client and the link worker. The link worker then supports that client to connect with those services and activities identified to benefit them and offers follow-up as required by that individual in order to meet those health and wellbeing needs. So to conclude, the integration of navigation, signpost and link worker services in the Northern Trust area highlighted a number of historic and now avoidable gaps and inefficiencies both in the care journey and the system overall. The clear and consistent needs identified throughout the engagement process have become very strong anchoring principles for us, for our service, and we remain true to these as they continue to be regularly affirmed in day-to-day practice. So those needs, coupled with the lived experience, our ever-growing learned experience, the robust data collection and analysis of that data, means that our person-centred Connect North team are committed to a dynamic service improvement which is responsive to meeting the needs of our people. Thank you very much for your time, and our details are on there. Thank you.
Thank you, Claire and Sabrina. That's fantastic, really innovative work. Edward Sipler, please come up.
Oh, so I'm going to have slides instead of just the poster, because the poster has small print. You know, my name's Ed Seipler. I work in the Southeastern Health and Social Care Trust and Health Development. Delighted to have an opportunity to talk about this, because when you talk about well-being, the well-being of our population, but also the well-being of our staff, what we know, in Northern Ireland here, 19% of people have a mental health problem, but only 30% get any professional help. Now, what are the barriers? Now, stigma's in there, but it's not the main one. The main two barriers, perception and need. And that's a real Northern Ireland thing. I don't know if it's like that in your part of the world. Yeah, I'm okay. I'm all right. I don't need that. But also the availability and this visibility of services. So they're the two main barriers. And the need for early intervention is embedded in our mental health side. How do we intervene earlier with those barriers? So what we did, the session we had before in this room was about collaboration and partnership. Now, Northern Ireland's a small place, so along with ourselves in health development and our trust, the Western Trust, that's only about 90 miles away, and ASSERT, one of our voluntary community partners, we took a series of written material that we had, 4 interventions. I'll tell you what they are. And these interventions have all been developed with service user involvement, heavy service user involvement, and they've been used extensively on a one-to-one work, written information. But then how do we help people help earlier? Well, let's create an online version of these interventions. So we created 3. One for parents. We took Dan Siegel's work in terms of working with children and improving emotional regulation. Self-compassion, because the evidence around self-compassion, when you practice it, and the amount you practice it, is linked to the benefits you get. So if it's online, people don't have to, they can read it, but they can watch it and hear it if reading's not their main style. And a low-intensity CBT-based intervention. Now, what we've been doing then from that is we've been training workers from September to now. We've had 12 sessions, 400 workers across the region. Now, that's why I said, you know, we talk about collaboration and partnership. Northern Ireland has 6 trusts. We have opened this training up to all 6 trusts. We don't care where they come from. And can I use a really nice word people love to hear? It's free. So that training's out there. We've got 4 more coming up. But when we did this training, we want to encourage our workforce to use these interventions. What did the training do? Almost 100% of those people, we did an impact survey. The 400 people, we got a 40% return rate. Not bad. That's acceptable. 100% of those people said, we got something we can use for ourselves with our service users. And 99.9% of people said, I've got something I could use for myself. One person said no, because they said we would be better getting a written copy of this work rather than digital. Well, that's okay. But the views, we're watching every month, the views on the clips on the online work are going up. The qualitative data, we were blown away by what workers were saying they were getting from this. This work changes lives, we're using it, it's helpful. But one team leader said, it has changed the way we work with people. You have given us tools now that can make a difference. So where next? Well, an added benefit, we weren't expecting this. 29% of people who gave us feedback were from the education sector, working with young people in schools, our communities. And the feedback they gave us, we're starting to use this material in schools. So what we're going to do now, because all the material is for adults, we have a working party formed. How can we adapt some of this material for young people? And I'm excited about that outcome. And another outcome that came, and I wasn't expecting this, Yes, this training is there for people to use it with their service users, but also apply it for themselves. From this work, one of our commissioners, our SPPG, asked me to do 3 support sessions using this material, and that's why I won't be here tomorrow. I have a section with the approved social workers across the region on using one of the interventions. So, where to next? We're talking to our commissioners. How do we support it? Share it with people. We're launching our 4th intervention on using the polyvagal theory. But the only way to go forward is working together. We do have a flyer. If you want to take this away, give me a shout. I'll be sitting down there. And if you want to take away the flyer with the link, you're more than welcome. Thank you very much. Thanks for the time.
No, thank you, Edward. And we're running a statewide mental health in primary schools project in Victoria and Australia. I think my colleagues will be very interested in chatting to you. Sandra Bartolomeu, now how do I pronounce your last? Perez? Perez, welcome, come up.
I'm sorry to put you through that. That was quite hard. It's Sandra Bartolomeu Pitch, that's in Portuguese. Okay, so I'm a nurse and I'm a prototype researcher. And I'm here to talk to you about patient-public involvement. That is not the area of my research, but it's something I'm very passionate about. I study integrated care for people with neurodegenerative diseases, and I'm trying to develop a model that improves their coordinated care. Now, I'm doing it with them because who am I to say what would good care look like? So I've become quite involved with bringing service users with me on this journey. And I thought it was important to come here and speak to you about this, although this is not my area of expertise, because my connection with other professionals in different countries is that actually a lot of our colleagues do this as a ticking box exercise because the funder demands it or expects it, and if you don't do a bit of patient-public involvement before you submit your application, you surely won't get funded. So you sort of rush, gather a couple of people, and you expect them to nod their heads and agree with your ideas. That is not involving patients in the decision-making or co-designing with them. So again, I'm not an expert, but here are some of our ideas in terms of what can be done. And I say our because I do feel that through my research journey, it's been crucial that my institution does believe that it's important to involve patients and the carers in decision-making. And you see the name Sally Dace there, and she's my patient-public involvement lead. Sally is a very expert contributor as a person that has lived experience with a neurodegenerative condition, and I'm very thankful to have her insights. Now, I know I only have like a few minutes and I can't take you through the whole journey, but basically what I want to tell you is that you should involve people from the conception of the idea, develop the idea with them until you actually implement the idea, not as a ticking box exercise. I would like to focus your attention on actually this part here where it says improved participants' experience with PPI ideas, what to expect from our interview. Wow, what does that mean? So a lot of colleagues can use it, or hopefully frequently use it, for example, to develop participant-facing materials like a patient information sheet or a consent. And if you don't do that, you should, because you want to make sure that people understand what they're signing up to. But I've put it there because I really hadn't considered when I was developing the interview guide with my group with lived experience. One of them said, well, I think you should send them some of the questions in advance of the interview, which my researcher head was like, ooh, I don't think my supervisors are gonna like that much, because it's almost like they'll have time to prepare. And then I was thinking, well, I am working with people that potentially have cognitive impairment or people that are completely burdened by their carers' responsibilities. Why should I not give them the time to think about these matters? I'm not trying to catch them. So I thought, why not? So I ran the idea through my team, and they were like, ooh, I don't think that's a good idea. I was like, well, We did ask them, and this is what they're asking. Why would, like, let's have a go. So actually, this simple change, like I've sent them a guide, like an email just to say, this is what to expect from our interview. I want to have an informal chat with you, and these are the sorts of questions I'm gonna ask you. And they were so welcoming. Like in the end of the interview, I always asked, you know, do you have any ideas about how I can improve the experience for future participants? And I said, no, this was excellent. Like I really felt comfortable. I had some ideas of what I wanted to say. They could really, you know, add their thought and their time and contribution into the project. And this was such a simple thing. Yeah. And the other thing I wanted to say is about dissemination. And again, we tend to involve them in the beginning and not in the end. So I was invited to present at BBC Radio about the project. And I invited one of my contributors to come and speak with me about how is it to live with a condition. I was there from the researcher perspective, but I have not lived with Huntington's disease, which is the disease I study. So the fact that she was there and she could speak about how it impacts her life while I was explaining why the research was important with her like seal of approval made such a big difference on the response of the public. So I just wanted to challenge you in really thinking on how, you know, you can capitalize on this relationship with your public of interest. That's it. Thank you so much.
Thank you, Sandra, and a really powerful anecdote that's going to stay in my head. Philippa Homan, please come and join.
Hi, did you know that 30% of patients who had a heart attack experience a new heart attack within 30 days? And do you know why? I will tell you a story. One morning, John, a young computer engineer, felt a stomach ache which he associated with a hard night out with his friends. At night, with his family, he felt a chest pain and he faints. At the hospital, John couldn't believe that he had a heart attack. After all, he was only 40 years old. During the 3 days at the hospital, John thought about his lifestyles. Food choices and tobacco haunted him. 1 month after discharge, he began to feeling better. With the daily pressure, he began to smoke again and miss the important medication. Do you know what happens next? The chest pain returns and he went to hospital again. My name is Philippa Homan. I'm a nurse, a community nurse at the Cardiac Intensive Care Unit in Coimbra, Portugal. And John's story is usual at my daily work. So, cardiac integrated care, it's a participatory research which aims to promote better coordination between cardiology and primary health care to avoid hospital readmissions. A research group with cardiology and primary health care nurses, cardiologists, general practitioners, pharmacists, and people who have experienced a heart attack intend to analyze and improve the user's journey through the healthcare system. With the results of the literature review, the focus group with all the involved healthcare professionals and patients interviews, this group will co-create IMIC integrated care pathway. Once validated, hospital and selected primary health care teams will be trained with the support of a manual created by the team that you can freely download in Portuguese. With this project, John's story would be different. Returning to the day of discharge, together with health professionals, John set goals to manage his cardiovascular risks. Through the Health National app, he is trained to make health records. On the day of discharge, an alert is given to primary health care about John's health status. A month later, John had an appointment with his family nurse to confirm that he continues to take his 6 medication and there are no side effects. She also congratulated him for the 3 days non-smoking. John feels motivated to manage his cardiovascular risks and maintains regular online consultation with his family health team. Thank you.
Thank you, Philippa. It'll be really exciting to see where that goes, and I wonder if mental health and support for mental health might play a part in your model as well. Claire Fordyce, please come and join us.
Hello. My presentation follows on quite nicely from Sandra's presentation around PPI. So this is a project we did. I work in Belfast Trust. I work in a PPI team. And we were looking at collaborating to make accessible information for seniors across Belfast. This really came about part of the age-friendly strategy in 18 to 21. Really a piece of work that was actually co-created, co-produced with lots and lots of partners across Belfast. So the council, transport, older people's groups, health, and lots of others, all co-collaborated to make this strategy be. And we have another one in place now, but part of the commitment that Belfast Trust made at this strategy was to make sure that we were providing accessible information for seniors across Belfast. Belfast Trust is huge. We provide a lot of services in hospitals and in community, and a lot of regional services. But it was kind of felt that older people don't really know what a service does or how to get it. How do they get a referral? What does that look like? And very often I speak to people and they don't actually know the name of the service they actually need. They know they need a walking stick. They know they need some equipment, but they don't know how they get that. So it was to try and unpick that information, make awareness better, and make accessibility better for people. So we worked together. It was during COVID. We worked together collaboratively with partners across Belfast Trust, across Belfast. We worked with older people's groups. We worked with the community and voluntary sector. And we worked with charities, and we worked with trust staff. And what we created was a booklet, which I have a couple here. There's only 2 left, and I'll tell you why in a minute, but there's only 2 left. I do have one here. So this was a really co-produced piece of work. So we sent out lots of questionnaires. We did interviews with people over the phone. I did online focus groups. And we worked together. We had a bit of a steering group with our older people's groups who really steered the questions we should put onto questionnaires. They really influenced what information should be in the booklet, what it should look like, who should it be given to. Sandra talked about dissemination. They also worked as talk to how do we give this booklet out? Where will it be? What will it look like? So they did all of that work with us. And really, we couldn't have done it. It would not have looked the way it looks without collaborating and co-producing. So because it was in COVID, I sort of worked behind the scenes making the booklet be something. And then it was sent back to the team, to the steering group, to the older people across Belfast. And they were able to review it, come back with feedback, influence what was in it. Eventually, we produced 18,000 copies that have gone all across Belfast. We used the older people's groups that we now have strong links with. They were able to give the booklets out, especially across when COVID was in place and it was more difficult to get to people. They were able to access groups across the city to give out the booklet. And it's been really, really well received. We're now in the process of reviewing the booklet. Because we're not in COVID, it means I can go out and meet people. So I've met with lots and lots of different groups across Belfast to make sure that we're delivering and reviewing a booklet that now makes sense for the next few years. We have an online version of this booklet, and we'll have another online version of this. We're also looking at accessibility online to make sure that this is not given in a format that's more difficult if you use an electronic reader. So it's just more accessible, and we're looking at language, ability to have this in different languages as well, because we're a very multicultural city, so it's just important that we have this in different languages for people too. So, 1 minute. So I suppose that really is me. I have a couple of these. If anybody's interested, just to have a flick through, you can do. We only have about 2 left because we've had 18,000 copies away out across the city, and we're looking to produce another 20,000. So it's just gone to the design team with a lot of work from the groups I've worked with. When we get the design back, it will go back to those groups. We will sit in a room, they will analyse it, they will red pen it, and they will bring it back to me, and they will influence how it looks and how we produce that going forward. So that's me. Thank you.
Thank you, Claire. Some really practical support. Shelley Doucet. Have I got it right or wrong? Welcome, Shelley.
So full disclosure, I did not know I was doing an oral. I did not get the notification. So is it 4 minutes, 5 minutes?
5 minutes.
Okay, perfect. Okay, so I was just jotting some notes down. I'm glad that I was one of the last presenters, so I had some time to gather my thoughts. Okay, so my name's Shelley Doucette, and I'm from Canada, where I'm a professor in nursing, and I'm also a research chair. So today what I'll be talking about is the work I do with the Centre for Research in Integrated Care. So I'm the director of the centre. We developed the centre back in 2018, and it's based out of the University of New Brunswick. New Brunswick is a province on the east coast of Canada. So essentially the main goal of our centre is to develop, implement, and evaluate integrated service delivery models. So the way we do our work is we do a lot of needs assessments at a provincial level, but also at a national level, identify where there's gaps or barriers in terms of accessing care, and then we implement evidence-based models of care within our province and oftentimes across other provinces as well. So I'll give a couple of examples of that in a moment. The work we do is across the lifespan, so we've done work with children and youth with complex care needs, all the way involving seniors with dementia. We use a multi-method patient-oriented research approach. So in Canada, we call it patient-oriented research, whereby we engage patients as partners throughout the entire research process. So they help us in terms of identifying priorities, identifying research questions, all the way through to knowledge translation. And we collaborate with a number of other stakeholders as well. So we have decision makers, clinicians, community partners involved in all of our research projects. And we also have a large team. So the center I direct, I have over 30 staff, plus we have nearly 30 graduate students as well who are doing research through our center. So we have several projects on the go. I'm just going to highlight a couple of them. One of them is that we're the New Brunswick node of the Canadian Primary Care Research Network. So this is a network that's been in operation since around 2015 or so, 2016, and it's funded through our federal government. It's nearly $20 million to run this national network that's all focused on primary care. So within this network, some of the work we do, just an example of a project is we have one right now called the OECD Paris Survey. So essentially, every province in Canada is doing research looking at how primary care is being implemented in terms of patient-reported outcomes and patient-reported experience measures, so that we can learn about how practices are working within our province, but also learn from across the country as well. And there's 20 countries involved internationally as well. So we're learning about how care is provided, like in terms of how we can improve care within Canada, but also informing internationally. And then one of the main initiatives, we do a lot of research around case management and patient navigation. So the research we do around case management is within this model of care, we have case managers who are registered nurses or social workers, work with the clients within the practices who are oftentimes the highest users within the practice, often going to emergency departments, to really develop an individualized, integrated service plan to help the patient around self-managing their condition and also helping them to utilize healthcare services more effectively, but also so that they're more directed towards their needs. So we've been doing that since around 2015 across Canada. We also do a lot of research around patient navigation as well. So I know that was talked earlier. How many? Two? One? Okay. Earlier, I think in the UK, I know we've heard about link workers. It's very similar. So essentially, we have patient navigators who help individuals connect them with services and supports, health and social services, to really match their unmet needs to available resources. So we host a national conference called the Canadian Healthcare Navigation Conference. If anybody's interested in learning about that, it is a virtual conference, so folks internationally can join in on that. We've been implementing a dementia navigation program within primary care for the last couple of years, just as an example of a navigation program. So yeah, we also do several scoping reviews using JBI frameworks. So we use to look at the literature to see what research is shown to be effective. And we host a number of events, as I just mentioned one example. So I'll just close by saying that we are very much, we love engaging with other folks. If anybody's interested in any of the things I've talked about, please do connect with me. I think my contact's at the very bottom, and I'll stick around. Thank you.
Very impressive off the cuff and very impressive suite of research that your centre is undertaking. Alison Holmes, come up and join us for the last presentation.
Thanks. Good afternoon, everyone. My name is Alison Holmes. I am a clinical specialist physiotherapist working in neurogerontology, and I'm also doing a PhD at the University of Limerick. We've heard in multiple presentations over the last couple of days about Ireland's ageing population and all of the issues that brings to our health and social care systems. But we work with a team for developing services for older adults that aims to promote integration of services. Older adults often fall victim to a healthcare model that focuses on treating single conditions in isolation, and it doesn't address the complexity and optimizing functional capacity. And we are sometimes quick to accept decline as a natural consequence of aging, as opposed to optimizing outcomes based on the person's individual needs and goals. We can also be guilty of focusing on GP, hospital and medical-based care systems, but what about all the adjuncts in between that support an older adult to age well and stay at home, or wherever they prefer to live? The Carlow Kilkenny ICPOC Community Specialist Team was established in 2021 in an attempt to provide an integrated approach to health and social care provision in line with Sláinte Care's right service, right place, right time mantra. The service covers 2 counties in the Republic of Ireland, and though they're put in under the same service, there's huge variation across the 2 counties in terms of their socioeconomic demographic in general from rural to urban, and lots of variations in their needs and their healthcare access. Even though it's a small area relative to Ireland, there's still a huge variation in terms of service accessibility across the 2 counties also, and with workforce issues, so access to things like home supports can become a bit of a postcode lottery. So we wanted to see what older people really wanted from their healthcare service, as opposed to assuming that we knew what they wanted. And to try and capture some of the variations in demographics, we decided we were going to hold 8 World Cafe style focus groups across both counties. So we held them in multiple locations, rural, urban, all community-based settings, to really try and make people very comfortable, very safe spaces, and to engage in really worthwhile discussions. So what were our results? 41 older persons with a mean age of 75, although that participants' age ranged from, I think it was 65 to 97 in older adults, which was great, and 23 health and social care providers, including third-party voluntary organisations, participated in the groups. 2 main themes were identified. And similar to what a lot of other presenters have mentioned today, these focus largely around access and communication. Access to things like in-person contact, access to transport, access to services within their locality, access to funding to provide services within the locality, and access to general supports to support them living at home in a healthy, safe way. The other big one that came through really strongly was the recognition of the person as a person and not as a condition by medical staff. So I think sometimes we can be really guilty of thinking we're doing a great job because we don't hear complaints. But in this population, sometimes they're just too polite to tell us we're doing a bad job. And sometimes we are doing a good job. But they usually tell us that, so we have to bear that in mind. So it was just really good to get out to the community and talk to people. So outcomes included lots of really positive actions within the service. So it included further engagement with stakeholders, feedback sessions, development of interagency collaborations, and also access to funding opportunities that we maybe weren't aware of previously. It's also informed a rapid improvement event which took place, on which my colleagues from the Carlow Kilkenny ICPOP team are presenting on tomorrow. So in conclusion, the poster probably should have been named optimizing the continuous loop of care rather than an end-to-end pathway, because I don't think that's something that's ever going to describe care for older adults. But the findings provided valuable insight into what both service users and providers want from their health services to make them accessible to older adults, to make it an environment in which staff enjoy their jobs, and thereby informing future service innovation and planning. Thank you very much.